presenting on secondary glaucomas. So, as the name itself says, it's elevation in the intraocular pressure with or without glaucomatous disc damage, and is usually secondary to an identifiable ocular or non-ocular disease. It can occur at any age, but more commonly seen in younger age group. It usually presents as unilateral cases, but exceptionally there can be bilateral presentation. What makes the disease entity clinically significant is that at presentation itself the visual acuity is less, with a very high baseline IOP and with an advanced disc damage. So there are studies done which define the burden of the disease. This study is done on the Indian population, and the next two studies are of the recent publication, where they show that secondary glaucoma is not an uncommon condition, and they also highlight on the most common causes of secondary glaucoma. So at SSCI, 18% of the cases seen were of secondary glaucoma, and the causes were post-VR surgery, neovascular glaucoma, and glaucoma following an eventful cataract surgery. It's important to note that 10% of the cases also included lens-induced and steroid-induced glaucomas. So how would an institute and private practice differ? So most likely the cases seen at an institute would include post-VR surgery glaucomas, traumatic, post-PK glaucoma, or the neovascular glaucoma. The private practice definitely depends on the type of the practice is being done. Maybe a general practitioner is likely to see steroid-induced glaucoma, post-cataract surgery glaucomas, or glaucoma in pseudophakia or the pseudoexfoliation glaucoma. But however, if a private practitioner is a VR surgeon, most likely that he will also see glaucoma following VR surgeries. So among the common causes, I'll be discussing the 6 causes. So the post-VR glaucoma and the glaucoma following eventful cataract surgery will be discussed in the next session by my colleague. So just to brief on the mechanism, it can present as closed angles and open angles. In closed angles, it can come as posterior pushing mechanism or an anterior pulling mechanism. So along with the history taking and examination, it is important to pick the findings on gonioscopy, where there can be angle recession or pigment dispersion or neovascularization. And B-scan helps in picking up the findings whenever the media is hazy, and then UBM will help in picking up the structures which are behind the iris. If there's a tumor or a cyst or a supraciliary effusion, can be picked up on UBM. So neovascular glaucoma can present as NVI or early NVI, florid NVI, or there can be neovascularization in the angle or in the posterior segment. So the management basically depends on treating the retinal ischemia, and also treating the underlying systemic disease becomes very important. Control of inflammation and intraocular pressure is also a definitive treatment. One point to remember here is neovascular glaucoma, if there is no obvious posterior segment pathology, it becomes important to rule out rare causes like an intraocular tumor. Lens-induced glaucoma, the two most common types would be phacomorphic and phacolytic glaucoma. In phacomorphic glaucoma, the intumescency of the lens increases, thereby increasing the lens thickness and causing pupillary block. And in phacolytic, it is basically an open angle type of glaucoma. In both the conditions, you will have to treat intraocular pressure and the inflammation, but the definitive treatment is basically by doing cataract extraction. So steroids are used in many of the ocular conditions like VKC, uveitis, and post-cataract surgeries. It is important to note that the most steroid, the strong steroids are there in the facial fairness creams used, and hence it is important to ask history of use of any facial creams. Even though the ingredient doesn't mention steroids, it is usually there. And one more important thing is steroids in any form, not only topical but also inhalational or oral or any skin ointments can also cause glaucoma and cataract. So pseudoexfoliation glaucoma, there is whitish dandruff-like material depositing on the anterior lens capsule, usually causes secondary open angle glaucoma. It's important to note that not all cases of pseudoexfoliation can develop glaucoma, but whenever glaucoma is there, it is more aggressive and it is known to progress fastly compared to POAG, and hence likely to need a surgical intervention. So traumatic glaucoma comes in a range of presentations. It can come as hyphema and angle recession causing open angle glaucoma. If there is a lens subluxation or a dislocation causing pupillary block, and also there can be other mechanisms by which glaucoma can happen. So the treatment of this is beyond the scope of this discussion. Last but not the least is to rule out the rarest causes of secondary angle closure glaucomas, which can be a intraocular tumor can present as an angle closure glaucoma. The least entities are the drug-induced angle closure glaucoma and also a ciliary iris cyst or a tumor which can also present as an angle closure glaucoma. So the take-home message would be secondary glaucoma is not uncommon. Early detection and treatment can be sight-saving. In suspicious cases, it is important to rule out the rarer entities. The golden rule still remains that the treating IOP is not the only treatment. We have to treat the cause in secondary glaucomas. Thank you.